Hello everyone, my name is Nkolika Nwankwo. I'm a PGY2 internal medicine resident at Mercy Hospital, Fort Smith. I'll be presenting this poster on paraparesis, profound immunosuppression and diabetes mellitus in a case of undiagnosed Cushing syndrome. In this poster, we report the case of a 34-year-old gentleman with a past medical history of diabetes mellitus and hypothyroidism. He presented to our emergency department with a 3-month history of leg weakness, inability to ambulate, and 40 pounds weight loss. Initial lab work in the emergency department revealed hypokalemia of 2.3, WBC was elevated at 12.2, magnesium was 1.5, chest x-ray suggested pneumonia, there was flat T wave seen on EKG. At this time, the patient was started on IV magnesium, IV calcium gluconate, and continued potassium replacement. He was then transferred to the ICU for further management. In the ICU, the patient was started on IV vancomycin and cefepime for suspected pneumonia. However, there was no clinical improvement. Hypokalemia also persisted despite adequate replacement. Meningitis pathogen panel PCR was negative. Pneumonia pathogen panel PCR was negative. HIV testing was done, it was negative. CT chest, abdomen, pelvis was done. CT chest showed necrotizing pneumonia. This is what we see in figure 1. At this point, Cushing syndrome was suspected. So, a random cortisol, midnight salivary cortisol, and ACTH were ordered. A 24-hour urinary cortisol was also ordered. However, this test is not done at our facility and had to be sent out. Giving patients CT findings, a bronchoscopy was also done and bronchial washing was taken for infectious disease testing. Bronchial biopsy was done, which came back negative for malignancy. Infectious disease testing of bronchial washing is what we see in table 2. At this point, infectious disease was consulted and patient was started on diflucan, giving findings of elevated midnight salivary cortisol and elevated ACTH. A diagnosis of ACTH-dependent Cushing syndrome was made. Patient was then empirically started on metirapone. His potassium levels gradually improved and his clinical status also improved. He spent a total of 10 days in the hospital and was discharged to follow up at a tertiary center for definitive management. At the outside facility, patient had a dotted scan which was negative for neuroendocrine activity. This is what we see in figure 2. He subsequently had bilateral adrenalectomy done. He was started on prednisone and fludrocortisone and discharged home. At follow-up, patient is doing well, he's clinically stable, he's ambulatory, and is closely followed up by his infectious disease doctor and his endocrinologist. Now let's talk a little more about Cushing syndrome. Cushing syndrome is a rare disorder. According to the National Organization for Rare Disorders, Cushing syndrome affects approximately 13 million people in the United States annually. It occurs mainly in women aged 25 to 45, and the incidence gradually increases after the age of 50. Cushing syndrome is a group of clinical manifestations seen as a result of chronic exposure to pathologically high levels of cortisol. In human beings, there are 3 major conditions that can lead to excess production of endogenous cortisol. The first and the most common is the excess production of ACTH by a pituitary adenoma. This is called Cushing's disease. The second is the production of ACTH by a non-pituitary adenoma. And the third is the excess production of cortisol by one or both adrenal glands, either from benign hyperplasia or malignant transformation. To make a diagnosis of Cushing syndrome, elevated cortisol levels must be demonstrated by 24-hour urinary cortisol, late evening salivary cortisol, as we did in our case, a midnight 1 mg or the classic 48-hour low-dose dexamethasone suppression test. Once the diagnosis is made, the treatment is aimed at normalizing cortisol levels. Effective treatment reduces morbidity, improves long-term quality of life, and reduces mortality. As seen in our case, patients with Cushing syndrome present with non-specific signs and symptoms, and these signs and symptoms can be seen in other medical conditions. Although Cushing syndrome is very rare, it is important for clinicians to have a high index of suspicion to ensure early diagnosis. It is also important to be aware of the complications of Cushing syndromes because this may be the way a patient presents the first time. In conclusion, there are significant comorbidities like hypertension, diabetes, infections, fractures, cardiovascular diseases associated with Cushing's syndrome. It is therefore important to make an early diagnosis, as this will reduce additional morbidity and may even prevent mortality. Thank you for listening.